I would like to welcome everyone for joining us for the Hospice and Palliative Pharmacist panel, Mitigating Injectable Drug Shortages, Costs and Risks. It is our desire to share information to assist organizations in addressing the injectable medication shortages while providing compelling data presented by the pharmacists who have previously faced similar challenges. They will be sharing their lessons learned, best practices, and expertise. Today, I'm joined by, first, Dr. Rebecca Bledsoe, Vice President of Pharmaceutical Care and Mission from Ohio's Hospice Dayton. Also, Dr. Natalie Latuga, PharmD, Clinical Pharmacy Advisor at Hospice and Palliative Care, Buffalo. And Dr. Bridget Protas, PharmD, Director of Drug Information for Optum Hospice Pharmacy Solutions.
Hi.
We received many questions during the registration process, which was very exciting. We've actually incorporated many of these questions within the panel presentations. As Betsy stated, we also have the chat function, just as a reminder for those just joining us, that you may utilize to ask questions throughout the webinar. I will present these questions to the panel during our session today. So either just immediately after their presentation or at the very end during an open Q&A. So we're going to jump right in and begin with Dr. Bridget Protas, who will be sharing some of the most commonly asked questions.
Thank you, Tabitha. So we're going to launch right into the fun stuff, which is drug shortages. So I'm sure every person on this call has struggled with trying to manage patient symptoms during times of drug shortages and may or may not be a little befuddled about what to do when you can't access the drug that you're so familiar with or the one that seems to be working well. Unfortunately, drug shortages have become more common recently. And so I'm going to go through some of the questions, the ones that are most commonly or frequently asked questions about drug shortages, certainly the ones that I hear on a regular basis these days. The first one is, where does the shortage information come from? From my perspective, and most pharmacists follow two different sources. ASHP, which is the American Society of Health System Pharmacists, has an excellent drug shortage website, which is publicly available. So if you want to do some sleuthing on your own, I've got the website there. You can pop into the drug shortages page and see what they have to say about particular drug shortages. They tend to sometimes give alternative formulations when available, and they'll also give you specific information from each manufacturer. The FDA, or the Food and Drug Administration, has a huge amount of information on drug shortages, but I will say that it is not quite as user-friendly as the ASHP site, and they tend to lag a little bit. ASHP tends to have the finger on the pulse, so to speak, since they represent pharmacists. Pharmacists report when they're seeing shortages, and they tend to report a little earlier to ASHP, whereas the FDA tends to lag. But the FDA does have the responsibility of receiving information from manufacturers when they're going to withdraw a drug from the market for whatever reason. So that will give you a tip to a potential for a future shortage. So understanding that information from both of those sites, it's different, and it's important to follow both, really. Certainly you can rely on your pharmacist to do that. That's part of what we do in our daily job is to follow those sites and make sure that we're on top of it. So another question we get is, do we know, do pharmacists know, does anybody know what the day supply or the volume remaining is? It's a really good question. ASHP and FDA sites do not provide that information. They can tell you that certain dosage formulations are in shortage, but they can't tell you how much might be left. They can tell you that manufacturers have it on allocation, meaning that it will probably only go to current clients and not other hospital systems that may have not used that provider in the past, things like that. But they can't tell you we've got 1,000 tablets left or we've got 5 vials left. The local pharmacy or the wholesalers can give you that information. So again, depending on the type of agency you work in, whether it's an inpatient or home care, you may want to contact your wholesaler, your pharmacy services provider, or your mail order pharmacy to see what type of supply they have left of a particular medication, especially if it's critical that your patient's supply not be interrupted. They should be able to give you a handle on, we've got enough for the next couple of weeks and we're expecting another shipment type of information, or they can say, we've got it covered. We may have to switch to a brand formulation for a few days and then back to the generic, so they can give you the heads up on that as well. Some people, if you think about most recently, sertraline or Zoloft has been in shortage. And so there was some swapping back and forth between generic product and branded product. Brands tend not to go into shortage. And that kind of leads me to one of the future questions. How do we develop recommendations for shortages for drugs, and how are clients notified? So for the clients of Optum Hospice Pharmacy Services, I actually write all of those drug shortage notifications myself. And I've been doing that for a number of years now. When I investigate, I get emails from both ASHP and FDA about what might be coming up as far as a drug shortage, my understanding of the market and the manufacturing process, and then understanding where those pinch points might be and how to manage them, all is involved in whether or not I'm going to send a drug shortage alert out to our clients. If it's a hospice med, like haloperidol tablets have been in shortage recently in the past couple of years, and tend to still be a little bit touchy here and there, and it's something that's very, very commonly used in hospice. I will prepare that document, send it out with an alert that suggests the shortage will probably last for this amount of time. These are alternative products you can use in the meantime. Fortunately, when haloperidol tabs are in shortage, the oral solution tends to still be available, or perhaps if the injectable is in shortage, the tablet is still available. So there's another dosage formulation that we can usually recommend. When we come up to something like an opioid, especially an injectable opioid, a lot of times when that one is in shortage, there's a domino effect, so that morphine injectable is in shortage, then hydromorphone is, and then fentanyl is, and then there's some kind of leapfrogging back and forth amongst the opioids. And so you really need a pharmacist and a prescriber to work together there to make sure that we're managing what's available and making good and safe recommendations on how to change between products when you need to change between products. So it's a team effort on how we develop those recommendations and how we advise agencies about the shortage itself. So if I see a potential shortage coming up, and part of that again is understanding the market and knowing which manufacturers have consolidated production, then I tend to I keep a closer eye on that med for the period to just make sure that the supply is going to be safe. I can't control it, unfortunately, but I can at least see when a problem might bubble up and kind of send an alert out. So those recommendations primarily are going to focus on the meds that we commonly use in hospice, so that we're not flooding you with every last little shortage out there. We really focus on a lot of types of things. Our recommendations then flow from that. If it's a drug that we use commonly for symptom management, we will send out alternatives. If it's drugs like for diabetes, metformin ER is something that's been recalled and is in shortage right now. So the extended release of metformin, if you weren't aware, is in shortage. But that's also something that generally we'll recommend to discontinue. And so our recommendations about how to manage that shortage might be different if it's something that's not a critical med for a hospice patient to receive versus one that is definitely necessary. So, and then what can agencies do given that increased frequency of parenteral medications? Really, I'm going to plug pharmacists over and over. Never forget to consult your pharmacist, because they can give you advice on how to change medications, how to change routes of administration, how to adjust the dosing when you have to change a medication or a route of administration. I also recommend, obviously you can rely on your pharmacist, but your infusion services provider will allow you some of that information as well. And if they are able to compound versus a commercially available injectable solution, that might be an option as well, although that can be expensive. So you've got to kind of think about what all of your options are. I strongly recommend, if you don't already, you develop a policy and procedure for how to manage drug shortages. And that helps you kind of think through all of the steps of what will happen if something's in shortage. Who do we talk to first? And an important component of that policy and procedure is how are we going to teach our patients and caregivers about managing a different drug and assuring them that we've still got safe and effective therapy. So bottom line is take a stepwise approach. A policy and procedure document will give you that stepwise approach. Spell out alternatives, what's necessary, what could be deprescribed, what other routes might be available. So there's a lot of information that's out there, and there's a lot of prep work that you can do so that you're not in panic mode when you suddenly can't get morphine injectable. You know who to call, you know what the steps are, and you can help reassure your patients and families that you can handle that. Next slide. Okay, so we are talking about Macy catheters today and how well they can work for us. So I wanted to touch a bit on rectal physiology and medication administration. Quick refresher, since I'm sure some of you out there have not used a lot of rectal med administration or perhaps have not used a Macy catheter yet. We have a diagram here just of the say artistic illustration of a rectum and some of the venous blood flow to that area and kind of what the catheter looks like and where it sits within the rectum. When, as pharmacists, we think about changing a route of a medication from oral or parenteral to rectal, there are a few considerations at top of mind that we want to think about. First of all is a small volume. So a microenema, which is generally less than 30 mils or an ounce of fluid, does not require voluntary retention. And so that makes it easier if your patient has altered mental state or changing level of consciousness. Alkaline pH, so the pH is a little bit higher. Now, how would you know this? It's reported in the drug information package insert types of things, but really be more aware that acidic solutions can be problematic, elixirs. So if you think the old Lortab elixir brand, a lot of elixirs are alcohol-based and those can be irritating to the rectal tissue, so you're generally going to want to avoid those. The drug formulation itself, water-based solutions are most readily absorbed, but suspensions do well as well. Not all drugs that are pulverized or not all drugs can come in a water-based solution. They just don't suspend in water. They're not compatible with water. So a suspension is what is formed at that point. And that tends to work better than a solid tablet and potentially better than a suppository as well, because you've got the medication in a very, very small particle that is more readily absorbed across the rectum. Obviously, clear feces makes sense. Retention time is important. The longer the drug stays in contact with the rectal tissue, the better absorption you're going to get across that rectal tissue. Understand also that this is an entirely passive diffusion process. There are no active transporters in the rectum as there are in the other parts of the upper GI tract. So if you have a medication that requires active transport across the membrane, it will not work through rectal administration. And this is, again, where you're going to have to rely on your pharmacist. But I will tell you, Neurontin or gabapentin is one of those medications that just does not work well rectally. And then finally, placement into the lower third of the rectum is important because, and it's good most of the time actually, it bypasses the first pass effect is what pharmacists like to say. What exactly does that mean? So when we say a medication can bypass the first pass effect, it means that, and this is the blood supply in the lower third of the rectum, it means that the drug goes into systemic circulation prior to being kind of chewed up by the liver or metabolized by the liver. That means that more medication potentially is available to the body because it's not metabolized to an inactive state by the liver first. And so that's when we think about bioavailability of medications. When you give an injection, it's essentially 100% bioavailable because you're injecting it directly into the bloodstream. when you take a drug orally, some of it is lost, damage in the gastrointestinal tract from acid in the stomach or chewed up in other ways or other sites of metabolism. And then it goes into the liver and then it's out to the body. So you've lost a significant portion of that dose before it has a chance to work. If you think about, the easy way to think about that is a common example like morphine. It's 100% bioavailability when it's given through an injection, right? It's only about 30%-ish available when it's given by mouth. So that's why our conversion rate between, or opioid equal analgesic rate between morphine orally and morphine parenterally is so different. So we think about 3-to-1 as being that ratio. And we think that when you take something orally, only about 30% of that final dose of morphine actually gets out to the system versus the 100% you get from injection. So understanding that liver metabolism thing is important. It also may help you predict how that drug will be absorbed into the body, but it's not specific enough to say, oh, well, if we're going to give this rectally, we need to reduce the dose by 50%, or we need to reduce or increase the dose by twice or double it. That type of information isn't out there. So one thing that I'm going to emphasize a couple of times is once you change routes from oral or parenteral to rectal administration, you want to keep a close eye on the patient and make sure that they are showing signs of symptom improvement and also not signs of over or under dosage or no adverse effects. Next slide. So I've talked a little bit about rectal, oral, parenteral dosing forms. The versatility of a lot of the medications we use and the routes of delivery in hospice is very important because we know those routes may or may not be available at all times. The medication classes here on this slide, so everything from opioids to all the way down to antibiotics, provides a really high level overview of what's available. So there's probably something in each one of those drug classes that can be given rectally. But there are also some in those drug classes that should not be, and Neurontin or gabapentin is one of the ones that I mentioned. It's an anticonvulsant. It cannot be given rectally. There are anticonvulsants such as phenobarbital that can be given rectally and absorbs very well. So understanding that there is something in each one of those classically used categories from hospice and palliative care pharmacotherapy, but not 100% of the drugs in each category. If you're going to switch to rectal administration, you want to, it's a change in route, it's an off-label route, you want to check with your pharmacist and prescriber to make sure that it is an acceptable route for that particular medication. There may not be a lot of literature to support it, but at the very least, we can look at the pharmacology of that medication and make an educated guess as to whether or not we expect the absorption to be good. The last thing I'd like to say is just because you can doesn't mean you should. And that applies to a lot of things. It also applies with medications. And really it applies with medications where you're giving them orally or you're injecting them or you're giving them rectally. In hospice, we're looking at obviously improving that quality of life. The first step needs to be a very critical eye towards what is necessary and what's really most needed for symptom management. And there I think about three things. What are the patient's goals of care, family goals of care? What's the time to benefit for that medication? And is it preventative or palliative? And then you deprescribe to reduce the number of meds that family caregiver is going to have to give to the patient by whatever route they're using. And it saves administration time, it saves pill burden, and it saves overall the clinicalness that family caregiver has to do for the patient. So for example, morphine, lorazepam, haloperidol, their time to benefit is very, very fast, less than 30 minutes to 60 minutes when you see onset of benefit. An antidepressant like Zoloft, maybe you could give it rectally. Maybe you want to taper off and decide not to treat if the patient's very end of life. Antibiotics, another one. Yes, there are some antibiotics that could be given rectally, but is that something that you want to do at that point in time? And that's going to be patient goals of care and what are the expectations as far as treating or managing an infection at very, very end of life. So again, looking at that, very important. So the next few slides, we've got a few of the most commonly used medications, and some of the literature review just a quick overview of the actual bioavailability of each of those, comparing oral to ME or microenema. We look at that information. Pharmacokinetics is important. So Tmax is something that pharmacists use quite frequently. It essentially just means the time that it takes for the medication to reach its maximum or its peak concentration of drug in the system. So, for example, methadone, Tmax is about an hour and a half when it's given rectally, close to 3 hours orally. And that varies quite a bit with methadone individually. Pain relief or onset of action can be much faster. So if you think about the peak time versus onset of action tends to be faster than peak time. For example, phenobarbital, I mentioned earlier, sometimes the solution or suspension type of administration can be faster and somewhat better absorbed than even a suppository that was designed to give rectally. So suppositories are compounded for phenobarbital. They're not commercially made. But there does tend to be, and there was a recent study, if you look at the references list, that showed that the phenobarbital levels were higher and more consistent or less variable between subjects with a microenema than they were with the suppository. So again, something to be aware of. Another thought process here when we're thinking about the Macy catheter, the process for using the Macy catheter is essentially to pulverize the oral med and administer it or blend it with a little bit of water and then administer that solution/suspension through the Macy catheter. The caveat there is very obviously we're never going to crush an extended release product for administration that way. But also, when we talk about opioids and controlled substances, there's an increasing manufacturing process to make them abuse deterrent. Any abuse deterrent formulation should not be crushed because the mechanism of abuse deterrent will render the drug inactive. And a lot of times we think about like OxyContin or MS-Contin as having abuse deterrent properties, and beta has naloxone embedded into the morphine preparation so that if someone had the intent of abusing it and crushed it, it would render the product inactive. But abuse or administered through rectal, you have to crush it. And if you crush those abuse deterrent formulations, you'll render them inactive. So be sure that you are understanding what that formulation is like before you attempt to crush it. And then just a couple of bits of information. The pharmacokinetic data over the next two slides, and actually if you want to just kind of scroll through the next couple of charts. This information is in a handout that you can get as part of the training and education materials from Hospice on the Macy catheter. But again, the studies you can see here are relatively limited, but we know that there's evidence of effectiveness either by observation or by limited studies. A lot of the studies are in pediatrics or emergency departments where route of administration from injectable or from oral was compromised and attempts were given to get the drug in rectally. Some of them are smaller healthy adult studies as well, and we've shown or demonstrated rectal absorption that way. So there is sufficient evidence for all of the formulations presented here. And we can recommend that changeover if it's necessary to continue the drug in that patient. But again, that caveat and something you want to understand from a nursing and prescribing perspective, but also from a patient and caregiver education perspective is once you change routes, especially if you're going to an off-label route, which you would be in this case, you need to monitor the patient and make sure that their symptom is controlled, that they're not overly sedated or they're not showing other adverse effects, and from potential for over or under exposure to the medication. So again, list of references there. We certainly have more of them available. Just reach out or submit a question through the chat box and we can talk about those a little bit more.
Thank you, Dr. Turner. Thank you very much. It's an excellent recommendation to have a medication management plan for shortages. So that is the best practice. So thank you for that. At this time, I do have one quick question that came up if you can answer it for us. Where are injectable medications obtained from, and why can't they just make more so we just don't run out?
That's a magic question. If there was a Willy Wonka factory of injectable medications, it would be excellent. A lot of the generic injectables are manufactured here in the States, but many of them are manufactured outside of the country. In India, some in China, but primarily India, and then Israel is another large generic manufacturing area. In the US, a lot of our injectable medications are manufactured in Puerto Rico. And if you remember a couple of years ago, I believe Hurricane Maria?
I think it was 2018.
2018, that hurricane really devastated Puerto Rico. The factories were destroyed. The employees of those factories, manufacturing plants, their homes were devastated as well. So even if a manufacturing plant was available and operational, the workers couldn't get there. So that was a struggle, and that really put a stressor on there. So when we think about shortages, it can be a hurricane, it can be COVID-19, distribution of active pharmaceutical ingredients and generics from other countries into the US, and just shipments of, your regular mail has been delayed. So it's a challenge. We can't always just make more. The FDA and DEA did work together to free up some of the opioid quotas so that more injectable opioids could be manufactured in the country. But again, you can't ramp up production as quickly as it's needed sometimes. And so we're kind of just in that pinch mode for a little while.
Thank you so much. That's fascinating. I'm sure there'll be more questions in regards to that. At this time, we're going to have Dr. Rebecca Bledsoe share her experiences with medication shortages at Ohio's hospice. Rebecca?
Oh, thank you. It's a pleasure to be here. Thank you for inviting me to share our hospice's Macy Catheter story today. Ohio's Hospice is an alliance of nonprofit hospice providers across the state. Within this organization, I've been with them for about 15 years, and I oversee the pharmacy services for Ohio's Hospice. And in turn, I work closely with the medical and clinical staff regarding the medication management of our patients. We have several hospice and palliative care inpatient units across the state. Our largest inpatient unit is a 52-bed unit located in Dayton, Ohio. As such, the Dayton unit has its own inpatient pharmacy to provide pharmacy services to those patients at the unit. Oftentimes, it's that Dayton unit that is first to encounter a national drug shortage naturally, with the pharmacist monitoring drug shortages. Unfortunately, we as healthcare providers continue to face unpredictable and threatening shortages of injectable opioids and other symptom management medications. And one such shortage occurred for us. The hurricane was actually in 2017. And that was the precipitous for where we felt the shortage effects from Hurricane Maria. There are a number of manufacturing companies there and hit hard. And it was that shortage woe, plus the capitation the US government had placed previously on the production of opioids earlier in the year, that literally and figuratively created the perfect storm. For our Dayton unit, we have a high usage of injectable opioids, morphine, hydromorphone, and methadone. And at the point, at about the beginning of October, we were down to just weeks of having enough to continue our usage at our current rate of usage. So our practice had to change, and it had to change quickly. Our vice president of medical care and our nurse education director had heard of the Macy Catheter, and it quickly became the solution to our problem in order to care for our patients. The Macy Catheter became our solution to the crisis, and given the success of the implementation, we never actually looked back. Next slide. Just to give an idea of what our usage had been and what it is as a result after implementing the Macy Catheter. Heading into the shortage crisis, our average usage was about 9,000 injectable medications. That includes opioids, anxiolytics and anticholinergics. By October 2017, when the hurricane hit, we were initially trying to curtail injectable usage. As you see, with October 2017, we hadn't had much luck. We had dropped from like 9,000 to 8,000, not enough to make it through for the shortage. By late October, we were working with the medical and clinical teams to begin using the Macy catheter. Our education team worked with the Macy team in designing and rolling out education and training in literally a manner of a single business week. After that implementation, we monitored usage, and by January 2018, we had successfully decreased our injectable usage by 70%. Based on our experience at our hospice inpatient unit, during this time, we noticed that the Macy catheter was faster than subcutaneous in controlling pain with opioids, and that we were able to control pain with less opioid dose adjustments. It also seemed very effective in most instances with quickly controlling terminal agitation and other symptoms. It appeared to be saving nursing time and decreasing medication cost and waste. And based on this, we continued using the Macy catheter and never looked back. So actually by January 2019, we had decreased usage by 90%, and that practice continues today. Next slide. Given the medical and clinical staff's observations, we wanted to gain a deeper insight into their experience. So at 1 year post-implementation, so now we're looking at October 2018, Ohio's Hospice conducted a nursing survey across all of our nursing staff. We composed a 10-question survey and administered the survey via SurveyMonkey. The survey asked nurses for their experience with the Macy catheter, specifically looking at effectiveness and comfort of the Macy catheter compared to sublingual and subcutaneous administration. We sent out 391 surveys and we received 191 responses back. And the goal of the survey was intended to assess the nurses, well, this particular slide, this question was intended to assess the nurse's experience with using the Macy catheter. By October 2018, almost 80% of those who responded had responded that they had cared at least for one patient with a Macy catheter, and you can see the distribution on this slide of their experience. Next slide. Not all nurses felt experienced enough to answer the remaining questions. Those that answer appear in the upper left-hand corner as answered. This particular question in the survey was asking about the effectiveness of the medication management of severe symptoms, comparing sublingual administration to the rectal administration with the Macy catheter. When comparing the sublingual route to the Macy catheter, 78% rated the Macy catheter as more effective, and 20% of the nursing staff said as effective in controlling severe symptoms. Next slide. This question was designed to assess perceived experience with comfort of administration between sublingual route of administration and the Macy catheter. Compared to the sublingual route versus the Macy catheter, 69 rated the Macy catheter as more comfortable, and 27% rated it as comfortable in comparison to the sublingual administration. Next slide. This question is asking about the effectiveness of the medication management of severe symptoms, comparing subcutaneous administration to rectal administration with the Macy catheter. When comparing those two routes of administration, 52 rated the Macy catheter as more effective and 40% as effective in controlling severe symptoms, which is pretty impressive compared to an injectable route. Next slide. Here we're assessing the perceived experience with comfort of administration between the subcutaneous route and Macy catheter. When comparing these two routes of subcutaneous to the Macy catheter, 82% rated the Macy catheter as more comfortable and 15% as comfortable in controlling severe symptoms. Next slide. Our last question on the survey assessed whether the nurse would be comfortable recommending the Macy catheter to a friend or a family member versus injectable. When asked if if they would recommend the Macy Catheter, 97% said that they would for their family or friend. So amazing recommendation results.
Going to have Dr. Natalie Latuga share regarding the Hospice of Buffalo's quality study. So Natalie, you have the floor.
Thanks, Tabitha. Hi, everyone. So I am the clinical pharmacist at Hospice of Buffalo, and we're located in Western New York, Buffalo area, and we're quite a large hospice, and we usually take care of about 4,000 beneficiaries every year, and about 1,000 patients in our inpatient unit every year. It's a slightly smaller unit at 22 beds, but typically quite full and very busy. So a little bit of background, Tabitha, you can go to the next slide. We started using the Macy catheter really late in 2015, so quite a long time ago. And the reason we started using it is we were really coming off the heels of a change in our pharmacy model, and we had changed from using a single contracted pharmacy that basically provided everything for us, including after-hours services and delivery service, to a more community pharmacy model that utilized 24-hour pharmacies, local chains, and a courier service for after-hours medication needs. So for us, with the loss of that, I'm going to say really high quality service from that one pharmacy, the Macy catheter itself was a very attractive option for after-hour symptom management, and we managed to bypass some of the challenges we were having with finding medications in the local chain pharmacies. Fast forward to early 2017, that was really the year of the medication shortage for parenteral medications. Early in that year, there was a shortage with Pfizer. Plant in Kansas went down because of contamination issues. And at the same time that year for us, our inpatient medication prices were through the roof. So we were asked by our administration to have the clinicians look at everything and see if we can get our costs under control. And when we looked at the medications that we were using, the ones that were driving the high costs were all of the parenteral medications. Some of the big heavy hitters were things like methadone, thorazine, chlorpromazine, haloperidol. They were all very high cost compared to the oral, and we used them so often that it was really driving up costs. So we had to do something and put something in place to try and reduce those. And so what we did is we set up basically some guidelines that recommended using the catheter as first line when the patient's swallowing failed, for all those who didn't have contraindications to using the catheter. And then after that, we obviously followed all the outcomes to make sure that what we were doing was safe and effective, and also to see our costs come down. So the results of the study were really quite interesting. At baseline, in 2016, we had only used 160 catheters in the inpatient unit and 139 catheters in home care altogether. But after we implemented this recommendation to use the catheter in February of 2017, we saw a 43% increase in catheter usage in our inpatient unit within the first month. And from that, we saw a 40% decrease in our medication costs that same month. We further looked at the medication usage and cost through March through May, and we basically were able to annualize the medication cost savings and factor in the increased catheter usage. And we predicted that we had an annualized net savings of $92,000 per year just in our inpatient unit alone, which was enormous for our organization. Now, the benefit of this presentation being 3 years from when we published this study is that, we didn't know at the time whether or not that cost savings would hold out for the entire year, and I can tell you it did. So all through the remaining part of 2017, our cost remained at that low, reduced 40%, and actually continues to stay there today, 3 years later. So this has really helped keep our medication costs down and keep them down consistently. Part of that study also was the quality component, because you can't just save cost and not care about what happens to the patient in the end. So we actually informally surveyed our nursing staff, and I especially paid very close attention to any kind of gossiping and scuttlebutt and griping that would happen when things got changed. And then very importantly, our staff really reported that symptoms remained effectively managed. And I know the nurses I work with honestly have zero problems voicing their opinions if they don't like something we change, or if the patients aren't being managed well. They're not going to stand for it. And they had no problems with this, and they actually really liked the catheter. And even today, they continue to ask for the catheter first line when the patient can't swallow. Even though we do fall back on our injectable meds quite often, the Macy catheter is right up there as an option. One of the things they really liked, they pointed out to us specifically, were the efficiency gains that they saw in their day. And we weren't able to really quantify those with our accounting data, but they were noticeable enough to the nursing staff that they had to mention it to us. And they centered around things like time saved during medication pass. It's easier to give all the medications at once through the catheter than each individual medication, or drop each individual medication out of a vial and inject it and then flush it. The narcotic counts at shift change really decreased in time as well, because you didn't have multiple formulations of the same opioid on hand. You didn't have oral morphine, injectable morphine, liquid morphine, all of which had to be counted and accounted for. And then the same thing on the disposal end when the patient died. You didn't have all this extra medication laying around. The cost savings in home care were a little bit harder to tease out, mostly because there's so many extra variables in home care that you can't really account for. It's not a closed setting like the inpatient unit. So what we ended up doing was modeling the potential cost savings using our actual pricing data and predict where we would see those efficiency gains. And what we most noted was the ability to quickly manage the patient in the home without having to make multiple phone calls and get orders and new prescriptions, and calling pharmacies to see if they have the medication in stock, waiting for the family to go pick it up, waiting for them to give it to the patient, and then the nurse having to double back around and check on the patient and make sure everything worked, and if it didn't, start all over again. So that was really big for our nursing staff, and it really saves them a lot of time during their day when they can just manage the symptom quickly and essentially be done with it and get the patient comfortable. The other areas that we saw reduced medication costs specifically were compounded medications and infusion orders, which I'll show you on the graphs coming up. Next slide, please. So this picture here is a graph right out of the paper itself, and it shows the cost savings from the HIU with the actual numbers and the cost per patient day over time. They do say that the pictures are worth 1,000 words, and this is exactly what our administration wanted to see. And you can see that at the beginning, our average cost per patient day before we implemented the change was about $35, and had reached as high as $45 previously in May of 2016. But after we implemented the change in early 2017, we saw this cost per patient day decrease down to about $20. And like I said, this $20 per day average is where we continue to sit through the rest of 2017, and is where we still continue to sit today. So it has really helped maintain that lower cost level. Next slide. This is another chart right out of the paper itself, and what it does is it looks at infusion data costs versus using the Macy catheter. So we did see a small reduction in infusion costs by a couple percentage points overall for the organization when we started using the catheter more, that we couldn't attribute to a change in practice because we hadn't changed anything else. And our infusion vendor does charge a per diem fee for all of their infusions, which is about $40 a day. So what we did here is we looked at the cost of the medication itself, and in this case, it's actually morphine PCA pump. And when you look at the $40 per day charge, it adds up over time. Whereas when you use the Macy catheter, it's a one-time charge to use that catheter, and that's the end of it with the medication. So by avoiding the infusions, we're actually able to save over $200 per week on per diem fees with the infusion vendor. And the next slide. And this is the last slide, and it's a table from the paper as well that outlined basically the clinical benefits that we saw with the rectal catheter, and tried to basically summarize what we saw. Most importantly, at the top of this list was symptom resolution for the patients, and also patient-centered goals to remain home where they wanted to pass away. Many of them don't want to come to the HIU or inpatient unit. Most of them don't want to go to the hospital. So by using the medications you have in the home, we're actually able to keep the patient home and not have to worry about finding new forms or new medications and substitute things, or transfer them out to a higher level of care. The other benefits, like I already said, were related to nursing efficiencies, and that actually translated to better care and the nurses being able to provide more care throughout their day, because they didn't have to spend time making lots of phone calls, finding things, and other regulatory issues like narcotic counts. It really did free them up to take care of more people. And for me, one of the more interesting findings of the catheter was actually being able to use it as a discharge plan. And in home care, we prefer to not use parenteral medications, mostly as a safety issue. When you have non-medical caregivers trying to inject medications, it's kind of a recipe for disaster sometimes. So sometimes what would happen is patients would end up in our inpatient unit. We get their symptoms managed with parenteral meds, but for some reason we can't get them effectively transitioned back to oral. And what we would do then is transition them over to rectal so that we could send them home without the injectable meds. And that works many times to get the patient home where they want to pass away. We've also used that as a plan too to get patients out of the hospital. Most patients in the hospital are always on IV meds, and they don't use necessarily the Macy Catheter in the hospitals. But I have plenty of patients who are, maintained on IV meds in the hospital, and the family wants to bring them home to pass away. And the only way to do that is with the Macy Catheter when they have no oral route that's available. So it really, a lot of really interesting and neat clinical benefits that come out of the catheter, and you could take a, rabbit hole dive and really dig out all the parts you want. And it's really been an effective tool to help us manage our patients on every level. So that's really it for my study. The study itself is actually available online. It's available open access, so you can actually pull up the paper if you Google it and read it for yourself and read all the nitty-gritty details that we put in there, and pose more questions after that. So thanks for listening to all of us talk.
We are at the top of the hour right now, and I would like to thank our panelists, Dr. Bledsoe, Dr. Latuga, and Dr. Protas. So we look forward to seeing you at upcoming Thought Leader series and webinars in the coming months, and we would like to wish you a wonderful afternoon. Thank you so much.